Hi guys, in this video we're going to discuss the organism Clostridium difficile, and like its name implies, it's pretty difficult. Not just because of the disease it causes, but also because it's really difficult to get rid of once it's causing disease in you. This is one of those bugs that presence of the bug doesn't necessarily mean that that's what's causing your problem. Lots of normal people who are completely healthy carry Clostridium difficile in their gastrointestinal tract at all times, and it doesn't cause them any problems. This is one of those bugs that when it overgrows or when it is expressing a certain toxin, then we worry about it. All right, so the C in C. difficile stands for Clostridia. And just like some of the other Clostridia we've talked about, namely C. perfringens, which we talked about in your cellulitis case in host defense, host response. That's Jamie Lopez for all of you Rush students who are following along. The Clostridia are all spore-forming organisms. This one is a gram-positive rod, as are all of the Clostridia, and it's anaerobic, again, as are all of the Clostridia. So this is kind of an interesting thing when we think about it. So it's an anaerobic organism, and it's going to grow really, really well in culture. The vegetative organisms can grow pretty rapidly. However, they are exceptionally oxygen sensitive. Oxygen is very toxic to them. So when you're taking a culture, if it is exposed to oxygen, your vegetative organisms are going to die off really quickly. But you got these spores. And the spores can then, once they get into a nice oxygen-free area, they can actually create new vegetative growth. So if you don't quite remember what spores are or how they work, go back to Jamie Lopez. It's all in there in the bacteriology self-study. But what this really means from kind of an infection standpoint is that it's going to be really, really hard to kill these guys because spores are really hard to kill. Remember, they're very resistant to heat and disinfectants, and they hang out on surfaces like, say, toilet seats for a lot of time. And if you are using the toilet in, say, a hospital where we tend to find a lot of C. diff, you could potentially pick this bug up. And if you're currently susceptible to a C. diff infection, it's going to have no problem moving into your gastrointestinal tract. It's a pretty commonly shaped gram-positive rod. Nothing to really report, just identifying the spores if you wanted to look at this picture some more. All right, so I mentioned at the beginning of the video that C. diff is one of those bugs that we actually carry in our gastrointestinal tract normally. It's present in many healthy individuals. So when does it become a problem? Well, it tends to become a problem when it's growing beyond what it should. So when you have a C. diff overgrowth. And this most often happens when a patient has recently been on an antibiotic. Clindamycin is kind of the classic culprit for leading to a C. diff infection. So basically you take the antibiotics, it wipes out your normal healthy gut microbiota, and that kind of gives C. diff an opportunity to grow a lot bigger than it normally is, and then you get problems. Clindamycin tends to knock out some of the organisms that typically keep C. diff in check. However, other antibiotics have also been associated with it, specifically like fluoroquinolones. So clindamycin is your classic example, but anytime you see a patient who has recently been on antibiotics that now is showing symptoms of C. diff, it's certainly something to consider. Disease is actually mediated by two toxins. You have an enterotoxin, which is toxin A, and a cytotoxin, which is toxin B. So when we think about the enterotoxin A, I want you to think of the kind of first type of disease that we think of with C. diff, and that's watery diarrhea, specifically foul-smelling diarrhea. It's said that like really seasoned nurses can tell you if there's a rampant C. diff infection on a floor because they can kind of just smell it out. So isn't that a fantastic image? But enterotoxin A, or toxin A, binds to the brush border of the intestines, and that's actually going to cause inflammation and also recruitment of neutrophils into the ileum. And once you have all of these neutrophils in the ileum, well, remember, neutrophils like to kill things. So the neutrophils are then going to go in and kill some of the cells of the ileum. and that's going to disrupt the tight cell-to-cell junctions, and that's what's actually going to lead to the watery diarrhea. So this is really, you've got this toxin, it binds to the brush border, that causes inflammation in the form of neutrophils, and the neutrophils cause death, okay? All right, so what's the other toxin? Because I would have thought that cytotoxin might involve death, but no, in this case, we're talking about cytotoxin for disrupting the cytoskeleton. So cyto in this case is actually looking at cytoskeleton. So cytotoxin, or toxin B, is going to disrupt the cytoskeleton of cells by depolymerizing actin. So this is an actin-based toxin. And what that's going to do is actually lead to enterocyte death and necrosis. So it's kind of killing it from the inside out. And this is what's actually going to cause pseudomembranous colitis. So for enterotoxin, if you're thinking about that watery diarrhea, with cytotoxin, I want you to think about pseudomembranous colitis. Pseudomembranous colitis is kind of this fulminant colitis where we actually see kind of this coating form on the colon, and it causes this yellow to gray exudate to form, and this exudate is referred to as, you guessed it, a pseudomembrane. And the pseudomembrane can actually be really dangerous because as it forms along the colon, it actually blocks normal water reabsorption, nutrient reabsorption. So that's what actually can lead to some of the other symptoms we see, and it also contributes to diarrhea. That's kind of the theme with C. diff. Just because the bacteria has the toxin, that doesn't mean it's going to cause disease. Because remember, disease is really associated with overgrowth, okay? So carriage of C. difficile and high levels of the toxin can actually be found in kids, even though we don't typically see C. diff disease in kids. So it's actually thought that as long as you have your healthy gut microenvironment, it doesn't matter if you have toxin-producing C. diff, as long as that microenvironment is keeping the toxin-producing C. diff in check. The minute the toxin-producing C. diff is out of check, well, then you now know what happens. Okay, so let's talk a little bit more about the presentations of C. diff. So as I just talked about in the previous slide, we're really talking about watery diarrhea for the most part, and it's often foul smelling. This is normally a pretty acute onset. Just all of a sudden, this starts occurring. It's characterized by at least watery diarrhea 3 times in about 24 hours. With your more commonplace C. diff infections, you're going to expect some lower abdominal pain, maybe some cramping. You might see fevers. If you do see fevers with this less complicated form, it's more of a low-grade fever, and the patient just kind of feels like they have like bad gastroenteritis. Nausea, anorexia. You might see some leukocytosis if you did blood work. And this is because all of these symptoms, the fever, the leukocytosis, this is actually because C. diff is characterized as an inflammatory diarrhea. So these symptoms are actually a result of the actual immune response to the pathogen, trying to keep the C. diff in check now with an immune response since the gut microbiota didn't. Pseudomembranous colitis is a little bit of a different story. This is kind of like a much more intense version of C. diff. So in this case, you're still going to have the diarrhea. And probably lower quadrant pain, but maybe more. And it may be actually at this point that it's gone diffuse, kind of across the bowel. On physical exam, you might see abdominal distension. You're much more likely to see fever. If the patient has been sick longer or has a really bad case, remember that this pseudomembrane actually inhibits water reabsorption. So in that case, your patient might appear a little hypovolemic. You can see some lactic acidosis, hypoalbuminemia. And then you can also see things like the leukocytosis, right? Because that is associated with both the watery diarrhea and the pseudomembranous colitis. But in this case, because you've got a lot more inflammation going on, you're going to have a lot more leukocytosis. So about 40,000 leukocytes per microliter. And this is actually a truly invasive disease, and that's what makes it so dangerous. So in this case, what happens is you actually get like invasion, which is what's happening up here. You see all this red. This is where the colon is being invaded, and that can lead to bowel perforations, sepsis, peritonitis, and toxic megacolon. And with this case, when you see patients with pseudomembranous colitis, they're not just experiencing diarrhea, but they're also going to get wasting because the nutrients aren't being properly absorbed. And in these cases, as we can see here, these are obviously not sections of colon that are still in patients. And that's because patients may need to have sections of the colon removed. Oftentimes, a subtotal colectomy is performed, and that might require only portions or all but the rectum, depending on how severe this pseudomembranous colitis is. All right, so how are we going to diagnose it? Because we can't just run around saying, well, they were on antibiotics and now they have diarrhea, so obviously it's C. diff. We need to be a little bit more careful than that. But you should certainly consider a C. diff diagnosis in patients who have significant diarrhea and some of the risk factors, which would be either recent antibiotic use, a recent hospital stay. Also, patients of advanced age, they tend to be more likely to experience a C. diff bout, and also close contacts of somebody who has recently experienced C. diff. So if you have a close contact that's even of a young age, but they were recently on antibiotics, you're going to consider C. diff in their differential. So diagnosis is made when you actually get either a positive laboratory stool test, and the laboratory stool test is actually going to look for the toxins. So it's going to look by either ELISA or PCR, both are possible. The key here is that you're going to want to make sure you send liquid stool to the lab. I know this is really appetizing, but you have to submit the liquid stool. And the problem, though, is that if you just send liquid stool and they find C. diff, you can't automatically go, oh, the patient has C. diff, right? Because you could just have asymptomatic carriage. So what you need is to be able to identify these toxins in a patient who has the symptoms. So that's why you're not really going to test everybody. You have to have somebody who has the right clinical picture for you to consider C. diff. The other way you could identify it is finding the pseudomembrane, that pseudomembrane that forms as a result of the cytotoxin. If you see that via radiographic or endoscopic examination, that's highly suggestive of C. diff, but you should still test the stool for the C. diff antigens. It's really not useful to do an eradication test for C. diff. I know we talked about that with H. pylori, but eradication tests don't really make sense for C. diff because of that normal carriage again. So really what you're just looking for is lack of symptoms. Okay, so treatment. The first one is kind of a no-brainer. If they're on an antibiotic and now they have C. diff, if they still need to be on an antibiotic, get rid of the implicated antibiotic. Most often that's going to be clindamycin, but we've also seen it associated with other ones like fluoroquinolones and ampicillin. Now, to treat the actual C. diff, because it is overgrowing, so you got to cut it down a bit, you can use vancomycin or metronidazole, and those can help with the severe diarrhea and the colitis. However, relapse is really common. 20 to 30% of patients will go on to have repeated bouts of C. diff. Some patients will even have 5 to 6 recurrences of C. diff. And in those patients, there are kind of some experimental strategies that are being worked out. But for now, stick with antibiotics and hopefully your patients don't experience too many relapses. That's it.